Hello everyone. Welcome back to another episode of Dental Digest with the Study Booths. This is Dr. Trehan and today we are going to discuss our next topic in oral pathology, Odontogenic Cyst series focusing on OKC, that is Odontogenic Keratocysts. Now these cysts are unique in nature, both from their clinical perspective as well as management. So they are going to be a high yield topic for your exams. Now in this video, we will go over their etiology, origin, clinical features, radiographical features, histopathology, complications, treatment, and then finally we will talk about differential diagnosis. So let's talk about OKCs. So these are developmental cysts that commonly appear in the second and third decades of life. And now OKCs, they expand primarily in the antero-posterior direction, which can result in significant bone involvement without much of your buccolingual expansion. And this subtle behavior can sometimes delay their detection. And they are also known for their high recurrence rate. Now an important point to consider here is that their association with Gorlin syndrome, which is also known as Nevoid basal cell carcinoma. Now, patients with Gorlin syndrome often have multiple OKCs, basal cell carcinomas, and even calcification of falx cerebri happens, which forms a classic triad, which you should keep in mind from your exam perspective, because examiner is definitely going to ask you a question on what is this triad, which is going to be multiple OKCs, basal cell carcinomas, and calcification of falx cerebri. Now let's talk about origin and etiology of OKCs. So do remember that they arise from remnants of dental lamina, also known as epithelial rests of seres. This is the only part that you need to know for the origin perspective. Now let's take a closer look at the clinical features of OKC. Now in the early stages, these cysts are typically asymptomatic due to their distinctive growth pattern, which involves expanding in the antero-posterior direction with minimal buccolingual enlargement. Now when symptoms do occur, they can include your intraoral swelling, pain, trismus, and in some cases, you can also have neurosensory deficits if the cyst involves any adjacent nerves. Another feature to watch for is delayed tooth eruption, which may occur when the cyst is going to be associated with any unerupted tooth. Now, clinically, mandibular ramus is the most common site for OKCs. And this makes it an essential area to evaluate whenever you're doing your diagnosis. Now let's look into the radiographical features. OKCs have a range of radiographical appearances. They often show up as well-defined unilocular radiolucencies with scalloped borders, but they can also appear as multilocular radiolucencies, making them look very similar to other odontogenic lesions. Now keep in mind that if multiple keratocysts are present, it is important to evaluate the patient for Gorlin syndrome. Let's look into the histopathology of OKCs now. Now the cyst lining is going to have at least 6 to 10 layers of stratified squamous epithelium, and a key feature is that it lacks rete ridges. Now the lining is wavy or corrugated, and most of the times it is going to be parakeratinized, but in some rare cases you can also see orthokeratinization as well. The basal layer is another standout feature. It has palisaded hyperchromatic cells that are going to be cuboidal to columnar in shape. And this basal layer, this is what contributes to the cyst's aggressive nature. Now, additionally, OKCs often form satellite or daughter cysts in the connective tissue wall. And these satellite cysts are the major reason for the high recurrence rate of OKCs. And that is why they can persist even after surgical removal has happened. Let's talk about the complications associated with OKCs. Now these cysts can cause swelling and bone expansion, but keep in mind that the buccolingual expansion is going to be usually minimal. Now the pain and infection can also arise, especially if the cyst is going to become secondarily infected. And obviously we have talked about that how there could be some neurological issues if the cyst is going to be very close to the nerves. Now the high recurrence rate of OKCs is obviously going to be another significant concern, which is often due to incomplete removal or persistence of satellite cysts after the surgery. Now although this is going to be very rare, there is a small risk of malignant transformation into squamous cell carcinoma. Now the treatment of OKC depends immensely upon what is the size and extent of the lesion. For smaller cysts, the main approach is going to be enucleation, where the cyst is surgically removed. And for larger cysts, marsupialization may be performed, first of all, to reduce the size, making subsequent removal very easy. Now, in more severe or recurrent cases, the removal of the portion of the affected bone, which is also called as resection, can also be done. And this is completely necessary to ensure complete elimination of the cyst. Lastly, as we have already discussed that these cysts have high recurrence rate, it is very important for you to follow up with your patients because that is going to be critical. Now, when diagnosing OKC, it is crucial to differentiate it from other similar lesions like ameloblastoma, dentigerous cysts, and simple bone cyst. Now, the reason why OKC is confused with that of ameloblastoma is because both of them can have multilocular radiographical appearance. Now, for us to differentiate them, remember that ameloblastomas are more aggressive and expansile in nature in both buccolingual direction as well as in anteroposterior direction. And to add, ameloblastomas can have a classic soap bubble or honeycomb radiographical appearance. Now, occasionally, OKC may also mimic a dentigerous cyst and involve the crown of a retained or impacted tooth within its lumen. But to differentiate between them, you need to look at the lining of the cyst. As in dentigerous cyst, the cyst lining is attached to CEJ, unlike OKC. Now, let us compare a simple bone cyst and OKC. Remember that a simple bone cyst typically shows minimal expansion and it lacks the epithelial lining, whereas OKCs are comparatively more expansile in nature as well as they have a lining, as we have discussed in the histopathological findings. So to reach a definitive diagnosis, always rely on your combination of clinical, radiographical and histopathological evaluations. Now let us wrap up everything what we have covered so far in OKC. These are developmental in nature and they originate from remnants of dental lamina, which are known as epithelial rests of seres. Then clinically, we talked about how OKCs are commonly asymptomatic in nature and they mostly expand in anteroposterior direction. Radiographically, they appear as well demarcated unilocular or multilocular radiolucencies with scalloped borders. Then we discussed the appearance histologically, what are the different treatment options we have to treat the patient with OKC, and finally we discussed differential diagnosis where we compared it with ameloblastoma, dentigerous cysts and simple bone cyst. Thank you so much for watching this episode. If you found this video helpful, give it a thumbs up and subscribe to our channel for more content. Let me know your thoughts or any questions you may have in the comments below. I would love to hear back from you. Remember to keep working hard and keep rocking. I'll see you in the next one.